This panel focuses on revolutionizing patient care. Can each of you provide specific examples of how AI is already achieving this? And what future advancements are you most excited about? As each of you answer this question, please tell the audience about your role and how AI tools and technologies play a part in your work. Would you like to start us off, Sajol?
Hi, I'm Sajol Ghoshal. I'm the CEO of a company called Advanced TeleSensors. So we build a touchless heart monitor, which is a device that mounts on the wall and can detect a patient's heart rate and respiratory rate without the patient wearing anything. This technology was developed at NASA, and we are really excited to bring it into a commercial space right now. So what we do is a radar beam is shot out from the sensor. It bounces off a person's chest, and we detect the micro vibrations of the heart and respiratory rate. From that, using what we call AI in the system itself, as opposed to large LLM models that were talked about earlier, we can extract irregular heart rates, arrhythmia, fall detect, apnea, and a slew of things that are going to come along with for that particular thing. So AI is a tool that we use, but the real value is what can we do to enhance and improve nursing of patients.
Good evening, leaders. I am Dr. Abel Guevara, based here in Austin, Texas. I am a medical consultant, and I specialize in optimizing healthcare revenue cycles. I serve as a vice president of DME and pharmacy for a workers' compensation company here in Texas. I as well love to work with new technologies and developing strategies for market access and getting it paid. So I've worked with multiple device manufacturers on identifying how we're going to get their equipment paid. But more specifically, I am also a advocate for student leaders, serving as on the board of directors for Texas State University, trying to find partnerships, externships, internships between companies and our student leaders. And then, of course, I specialize in optimizing rev cycle. So as you know, our CEOs are always like, get me the money, where's the money? And we are trying to do it as fast as possible with our limited resources. And by doing that, I integrate artificial intelligence and automation to support our staff by increasing the amount of money we collect in a timely fashion.
Hey all, Andy Mathis. I'm the Chief Partnerships Officer of Neuro Rehab VR. So I'm the VR, expert, if you will, in the panel. I've been in the space for about 10 years and applying it towards healthcare as best as I can and we can as part of the team. In terms of what I see revolutionizing healthcare and how AI can do so, I think we're seeing it right now in terms of automating documentation. The number one issue, often in the many countless surveys that are done about, clinician burnout across the board, the number one factor that's cited, both anecdotally, any doctor I've ever talked to, any therapist I've talked to, but also the data, the broader data says, it's about dealing with the administrative overhead and the documentation. It's just a total nightmare. And so I see AI actually being highly effective already in helping to automate that. And I'll quickly share, and then I'll pass it on to you, sort of down to the micro, how we're embracing AI in that way as Neuro Rehab VR is our patient and clinician customers. They use our VR services to essentially empower the patient to be more motivated. They're in VR and they get more excited, they get better results, and the therapist at the end of the session with a patient can click just one button, end session, well, two buttons, sorry, end session, and then generate therapy notes. And it automates SOAP notes for the clinician, just done. And if they want to, there's one more button press. If they want to send it to their email, they just doop. So it's just an example of how AI is starting to really help in that way.
I think this one works.
Cool.
But I think there's a reason why we sat next to each other, too, because we need to talk some more. I'm Toni Swinton, and I am currently the VP of Clinical Education for HCA and St. David's Healthcare. And I have been in clinical education for a very long time, since the days of no residency programs. So for the people that are in the room that send their students off to residency programs, I predate that in clinical education. So how AI works for me today, like I was sharing with some of my colleagues here, we've got our pinky toe in there. Right, we're using reactive AI in our learning management system, and it's titled Jane. I don't know where the name Jane came from, but that's what we selected. It's all lowercase, Jane AI, and we started down this path probably around 2017, which was timely because in the post-COVID world, if we're there yet, right? We realize that there's a real need for speed from the time that our team members graduate their programs to the time that they're functioning on the unit with any level of competence and confidence. So Jane AI uses tons of data. They say greater than 15 million data points for the data analytics people in the room. And they've had probably about 95,000 participants in the 30 years that PBDS, which is the base foundation of the system, has been in place. So they use knowledge assessments, which we're looking for some, like for the educators, the Bloom taxonomy sort of response from the knowledge assessment. But we're also integrated Watson plain language to support our clinical judgment assessments. That is a space where we have the opportunity to personalize the future state of their orientation. So they come through the door and they have these assessments, but the clinical judgment piece, which is the critical thinking that you guys have taught them, and then they take that and they translate it into clinical practice in the form of clinical judgment, we're looking to see that as soon as possible in order to move them through the orientation process. So that's where we are using AI in to me, a very small capacity compared to what we've heard all day today to support healthcare and the workforce for where we aim to go.
Thank you. So my name is Madan. I'm the Chief Technology Officer for Texas Health and Human Services. I support all of the different types of healthcare practices that you can come across, from direct healthcare in psychiatric and long-term care disability population facilities to public health. You know, I was in the middle of all of the COVID dashboards and everything back in 2020 to Medicaid and the whole payer and managed care space. So I'm in charge of now the implementation of the AI strategy. How do we safely, securely, and responsibly implement AI in the organization, both within IT and across all of our 200 health programs? So this is how I'm envisioning it. This is how we are starting. Our main use case is around knowledge bases. Literally, we are taking what you all teach here in the college for various professions, including caseworkers and social workers and people like that, the support staff around healthcare, and operationalizing their day-to-day skills. There is an enormous amount of policy, rules, criteria that they have to constantly understand. It's impossible. There's a huge backlog, with COVID, post-COVID, and so it's almost impossible for a human being to really master that. And so we really are we are doing pilots with Google, with Microsoft, and it's very promising. Obviously, all of us here have a graduate school background. You go through proper testing and validation, hypothesis. We all learned that in school. So that's ingrained in me. I also was a faculty member for a few years in Ohio. So I want to approach things in a very systematic way. So what I'm advocating for is a test environment for everybody, the sandbox that you heard in the morning, so that people can get there hands dirty and they can start to work on AI. So knowledge bases are a big one. And the other one everybody talks about is predictive analytics, which is really the deep learning, classical AI. There, of course, you heard about bias, you heard about, responsibility, and how do we make sure that, what is coming out is extremely valid and representative. There are some very easy use cases to start with, which is fraud and waste detection. So there's whole Inspector General that's doing their own data science with this. But what I wanted to have you all envision is how AI is changing healthcare across the various spaces. So I see healthcare as a cube. So one edge of the cube is everything from the community preventive care space all the way to the tertiary and quaternary space like the skilled nursing homes and the hospitals. So that's one edge. The other edge is all the different roles, the physicians, the nurses, and all of the supporting healthcare and the various healthcare professions. And then the third vertical is the administrative side, which is everything from patient engagement. So there's a big push for using AI there, and making sure that their experience is smooth. And then the patient-physician communication, we talked a little bit about that already. But I think the biggest thing is the revenue cycle that was mentioned. That's going to be the big neutron star, which is going to pull AI, because at the end of the day, AI has been funded by private investment, and they're going to want that return on investment. And so everything else is going to revolve around that. So I'm working through all of that, trying to figure out how to do that responsibly, but also very quickly, because there is enormous pressure from everywhere to say, they're seeing this promise of AI, why aren't we sort of doing it? And I want to take a very systematic approach. And so I'm very glad that we're having this to give me an opportunity to learn from everybody else also.
Thank you. So augmenting healthcare workforce is our key theme. How can AI help address existing challenges like staffing shortages and burnout, while ensuring human connection remains central to care? Toni, do you want to start us off?
So for any of the CNOs in the room, I think you shouldn't listen to this part of the conversation. And I say that because when I think of staffing shortages, we have multiple schools of thought around what does it look like to onboard someone into an organization. And for me, my personal bias is an individualized onboarding program and process. And historically, we live in a space where, it takes 4 years, or historically you had 4 years, of 8 semesters to get a bachelor's degree. And then along the way, it became, well, you can take some classes over the summer, or you can come into your undergraduate program with all of these credits, whether it was AP or dual credit or all of those things. So we started giving high school students credit for what they already know. And so for the adults that are coming into our organizations, I think there's an opportunity to utilize AI like the Jane competency assessment system to give adults credit for what they already know. Whether that's a new graduate nursing student who has spent the last 10 years dreaming of becoming a nurse and working in multiple healthcare environments, whether they were a pharmacy tech and then they were maybe a surgical tech. And then they come into our ORs as a new graduate RN, and we say to them, you need 24 weeks of our residency program. But I've been a surgical tech, I've been a pharmacy tech, there's all these things that I know. Give me this Jane assessment. If the Jane assessment says this person maybe just needs some time on the unit with human beings, making that connection, we give them the opportunity to do that. We do it with contract labor. We do not expect them to need 24 weeks. But we do with our new employees, we have a different approach. So one of the things that I endured during the first few months of COVID was trying to figure out how to transfer skills for the people whose business departments were closed, shuttered. There was nothing we could do about it, putting them to work elsewhere. And we had just started this work on Jane, and if it was in the state that it was in today, I imagine that period of time looking very different, because then I could use that PACU nurse in that surgery center. I could apply a Jane assessment, and then it tells me they've got the skill set for me to put them in that ICU where we desperately needed them. We were doing a lot of really inefficient things to try to make those assessments to do that same work. So no one's praying for COVID to come back, but if we had this opportunity to utilize that, that would be a demonstration of that. So I'd like to see that same principle used to onboard and continuously assess our clinicians, whether they're nurses or other clinical personnel.
Sharing personalized education by way of AI, so we can help with reducing staffing shortages and burnout, because not only can they be across modality and get to enjoy a few different things, you're also helping them get out of orientation sooner to address those staffing shortages.
Yeah.
Okay. Andy, you talked about automation. How do you think that automation would help us with addressing staffing shortages and burnout?
Yeah, a couple ways. I mean, I'll maybe dive a little bit deeper into the documentation piece. So automating the documentation, just an easy way at the end of a session, whether it's a PT, an OT, a speech therapist, mental health therapist, utilizing AI to just remove the burden of note taking. So that's one way. And this gets down to the level of making, suggested approaches for care moving forward, so it doesn't only just reduce the burden of documentation, it can also help guide the therapist in what they want to do with the patient moving forward. But a very VR specific dynamic, it's a little bit futuristic, but at the pace of AI's evolution, maybe not so futuristic, is being able to send patients home with a headset and continue their care between visits to the actual site. And so this reduces a lot of overhead for the hospital. It can also serve as an additional revenue stream ongoing, and it definitely serves as a means for a patient to make progress between visits with a doctor. And this is the futuristic part that gets a little bit, but I'm curious if you all think this is getting too far ahead, but there is VR. When you're in VR, how many of y'all, by show of hands, have tried VR before? Okay, wow, that's a great, okay. So you understand the immersive quality of it, and the introduction of brain plasticity. You can learn, you can improve more within an immersive environment. When you introduce an avatar, and AI is getting better and better at essentially serving as a means to, the avatar is a personable character that can help carry forth your motivation and can respond to your needs in ways as it learns. And so I do see the take-home VR headset in time also having avatars that can help serve to kind of address some of these staff shortages, not replace people. It's not a replacement, it's simply an interim solution between visits.
So I want to piggyback off of some of the statements. So clinical documentation in the rev cycle, very challenging for us to prove medical necessity for every single procedure and every single type of piece of medical equipment. So I like to talk about a story about me. So me starting off and trying to get something billed, we used to read paper medical records, find the ICD-9 codes. Back in my day, there was about 15,000 ICD-9 codes. Now we're at more than 69,000 ICD-10 codes. And so I always like to tell my new hires or student leaders that, okay, back in the day, we used to read medical records for hours, trying to find and prove medical justification of need to get our procedures and medical equipment covered. Now with augmenting to utilizing artificial intelligence, I can speed that cycle up and use OCR recognition if there's still handwritten notes, or more importantly, have my reps scrub through EMR systems to find and prove the ICD-10 codes for what we need to get billed. So when we talk about, streamlining, augmentation, I'm not getting rid of any employees. I'm pushing them to use AI to become kind of the supervisor of their departments, the specialists, to find it faster. So that way I can collect money faster, minimize any denials in the back end, and make the CEO happy because we have revenue in the bank.
I love that. So whenever I'm hearing from Andy, not necessarily you're doing decreasing length of stay for some of our patients, and therefore taking off that burden of a very important bed capacity, which is very limited here in the Austin and across the nation. So therefore, the staffing shortages are mediated because we can reduce length of stay and have that patient at home utilizing VR. Love that. Anybody else from our panel that would like to jump in on that?
Nation of care is huge in the mental health space when more and more the emphasis from payers is to try and do long-term care of any kind in the community. And so that's a big challenge, because if they're not inside in a facility and they are dependent on doctor's visit, they're dependent on periodic checkups, and particularly with medications and things like that. It's so there's just not enough people in that field. It's one of the most severely affected areas in medicine for a long time, and the numbers are just increasing. So having a methodology and a framework community-wide that can help with standardization. Standardization is so big in diagnosis and treatment and intervention that it's being developed. The EHRs are getting smarter, and the newer versions are coming out with those capabilities. But the other piece of AI is it has to be available everywhere, right? I always, the newest thing I have now coined is, do you want a client 360 or do you want a client prism? And people are like, what? So a prism is what breaks light into 7 colors. You don't get the color you want. So what happens today in healthcare is you have a lot of prisms. You have the privacy prism, the security prism, you have the payer prism, and then you have the federal regulation, state regulation prisms, and then, let's be honest, you have programmatic rules that are prisms. So it's really funny. Yesterday I had a conversation with General Dynamics, and they were saying, I said, can you speak to a situation where in the federal government we are connecting Veterans Administration with like Medicare, and it's really challenging because of these prisms. So the standardization and the AI needs to take into account those considerations also, and you have to go through a level of governance where everything is approved, and that has to be streamlined as well. I just don't see how that can be done without artificial intelligence and without some sort of proactive workflow. And so when you move towards value-based care, more and more healthcare in America is moving towards value-based care. I don't know how you do that without this kind of an ecosystem. It needs to be thought through at a very high level in a health system scenario, because you cannot afford, it's the triple aim, right? You have to have the best patient experience, you have to have very high quality healthcare, but you also have to keep your costs down.
All sounds so easy.
In somebody's head, it probably is.
Whose head?
Thank you. So healthcare data systems are complex. How can AI be used to improve data management, analysis, and sharing while prioritizing patient privacy and security? Madan?
Sure.
Sajol?
Yep. So let me give a little bit of a perspective from a device manufacturer standpoint, right? So we see AI as a very powerful tool, but it's not the solution, which a lot of people keep looking at as this is the solution. The solution is the outcome that you're trying to get. What is the outcome you're going to manage? So let me give you an example of an autonomous car. Today you drive a car, let's suppose you're not driving an autonomous car, you get in your car, you open the door, you turn the ignition on, turn the steering wheel on, and you're driving. If you got an autonomous car and you have a complex dashboard that you got to push a whole lot of buttons to tell you what exactly to do before you can even get in that car, you've not understood the workflow of the person who was a driver before, right? So devices that we bring to the medical world, which are AI embedded, must be in line with the workflow. So the workflow is really important. Well, we learned a lot about workflow from COVID, right? We saw the system get stressed out, and we saw nurses under a tremendous amount of strain, and the strain came from just handling a lot of things. So what we are doing with this medical device is just imagine a world where this medical device that can monitor someone's heart rate continuously will only send alerts to your nurses and doctors when it detects an abnormal rhythm. In the meanwhile, nurses can focus on patient care and not be running around handling emergency things every time because of the system you have in place. But at the same time, we can't have a nurse increase the administrative duties that come along with this new technology, because that's not worth it. So it should be transparent and should be part of the workflow and integrated into the EMR so that there's almost zero effort to support this.
I love that. Being a nurse, everything seems to fall to the nurse's shoulders, and that is one thing that we need with AI trends in healthcare, is that less needs to be on the nurse's plate. So I love looking at alert fatigue with nurses and being able to remove that, right? So I love hearing that from you, Sajol. Andy, do you want to weigh in on some of that?
Actually, I like your concept of nurse fatigue. So I'll go back and use an example for us in the rev cycle. So in order to get like a PAP therapy device, like a CPAP, BiPAP, cerebral vent, I have to prove compliance to the payer, Medicare, ensuring that the patient's utilizing the machine 70% of the time within a 3-month period, et cetera, et cetera, et cetera. We used to, back in the day, have the patient bring me the machine, download the information, have a specialist look at it, a respiratory therapist, identify areas of opportunity to ensure that that patient is using it, have the discussion. I mean, we were spending hours trying to get a patient to use their PAP machine. Technology started getting smarter. We started utilizing AI in our rev cycle and EMR system. So now we used to have to drive a van near the patient's home, download the data via wireless from the patient's device to the van. Now we're using internet. So I don't even have to send anyone to the patient's home. We're getting the alerts if a patient's being non-compliant that day. AI sending my RT a ping saying, hey, by the way, patient XYZ didn't use their PAP machine last night. Guess what? We're going to go and have that conversation with them and ensure that they're going to use it, because if not, then Medicare is going to pull the money back and say, you're not getting paid for that device, the patient never used it. So utilizing AI, having that data information, because eventually my pulmonologist is going to ask for the information. I can send that to them to make clinical decisions that we used to not be able to do. So we can have those informed discussions with the patient prior to any deficiency of not getting paid. So that's what we in the rev cycle love about some of the smart technology. Even though it's not with medical billing or coding, it's alerting and allowing us to streamline our operations. And again, once again, preventing burnout of our respiratory therapists.
I think I'd like to add to that. Just considering your comment about the triple aim and IHI, and in my world, I deal with a lot of like human factor related education requests and competency validation requests. And sort of what we like to call spray and pray when something occurs, and you try to educate everybody as a resolution to that. But with human factor, humans are prone to error. We have poor memories. We wake up in the middle of the night and make a note tomorrow to do this at 3 p.m., right? And like, so for example, for all of us that are nurses, on October 1st, we started to ask flu. But for several months, we didn't care about flu. We didn't ask anything about flu. Flu was turned off on our EHR, and then all of a sudden, I come in at 7 a.m. on the 1st. I need to remember to ask everybody about flu, because that's reportable. And not only do I need to remember to do that, but I also have to chart it in a very specific space so that our data guys can pull it. So you talk about administrative burden and burnout, and then we have human factors for good outcomes or high quality outcomes because of value-based purchasing and all of that. And if I go home, somebody's going to say, you forgot to do flu and now there's an issue. And then they're going to call me and say, put out a huddle card or a potty point for the older nurses that says, please do flu. Well, where is AI that can tell me on my iMobile device, hey, I don't see anything about flu. You've been here for 8 hours. You admitted 3 patients. These 3 patients don't have flu. Reminder, like our old GPS that used to say, redirecting, and drove us crazy because we knew a better way to get to wherever. A reminder, I need reminders. We're human beings and those errors are not purposeful. So there's an opportunity there that does not impact patient privacy. It works within the EHR system. It prevents my team from constantly posting potty points about something that by nature we simply cannot easily accomplish when there's technology that can help us to fix that, essentially.
Great points, Toni. And I think also with Madan, in terms of the PRISM look, we have our government's flu track registry that when you get a flu vaccine or any other vaccine for that matter, it goes into a repository. Why aren't our EHRs set up to utilize that kind of technology or to incorporate that? So looking at your PRISM, there's so many different PRISMs and so many different documentation systems. It would almost seem like the intent would be is to have something that is an overarching goal to be able to communicate and using AI instead of it being a person-dependent task, having automation.
So I'll draw a contrast. So I was talking to our keynote speaker during lunch, and I said, what got you started? The reason I brought up that question is because I often wonder, why are we talking about AI today? What happened, And so in his case, it was because he was just interested in understanding the human brain. So part of the challenge we have is this: you look at our body as a system, right? We all study medicine has systems. The systems interoperate brilliantly. In fact, the first sign of disease is when the systems stop interoperating. Why aren't our technological systems designed the same way? So I think there is a huge market in enabling human beings by making the technology work together. And I'm not saying this is intentional, but it has somehow happened through the fact that all the funding has come through private investment, that clearly there is a huge incentive for return on that investment. And so the reality is each one of the manufacturers would like to own the marketplace. I mean, 90% of the US EHR marketplace is owned by 3 vendors: Epic, Cerner, which is Oracle now, and Meditech. So what incentive do they have to interoperate? So I think where it starts off is with the college and places like ACC and health sciences, because today the careers are very siloed, and rightfully so. You have somebody who's a nurse, somebody who's a nurse technician or a medical technician. The fact is, when they're treating patients, it's a team. People are a team, organizations are a team, the systems are a team, the processes are team-oriented. That's the reality. When they work like that, they work brilliantly, like Kaiser Permanente and a couple of others. They have some very good success stories. Most organizations have not reimagined their workforce in the light of the explosion of technology and systems in healthcare. We have the same problem. I don't know who, it's like, who will build a cat? I think I am a great believer in academics and the power of academics. And so this morning we had the Higher Education Coordination Board Associate Commissioner. I think a lot of it has to do with accreditation and the way those things work and how, the profession as a whole has been set up. Data will not fix itself. The things you're asking for will not just happen in a vacuum. You have to have a concerted effort. So one of my suggestions, at least for the colleges, start locally with the local institutions like St. David's and others, and come up with a task force that addresses this problem from 2 places. One is from the workplace perspective, and then the other one is from the work preparation perspective. I have some ideas that we can get into if we have time. So I'm sure places like St. David's are giving you great feedback on what they're looking for in their workforce, but it could be bi-directional. You know, the students and the staff and the faculty could also give them some suggestions and recommendations and create like a synergy between the two. So you could have innovation labs here in ACC where some of these things are tried out before they go into because you can afford to make some mistakes here as part of learning. Like we heard this morning in the panel on healthcare education. So you could do some of those things here that they cannot, simply because they're highly regulated and also, just finances. So I think the key is for AI to work is that we have very high quality data. And for the very high quality data, we need seamless interoperability between our systems. And if somehow we have to find a trigger to make that happen, that's been my holy grail for 16 years. I was on the national panel for Certification Commission for HIT in 2008, and we were talking about this then, and I can go on for hours about it, but I think you have an opportunity here to do something.
Thank you. So what are some of the biggest hurdles to wider adaptation of AI in healthcare, and how can we overcome them to realize its full potential? Sajol, will you kick us off?
So, in terms of obstacles for AI and its deployment, one of the challenges I face, because I'm new to a lot of the medical world, is it's a very complex system. And it's multi-layered, and I have to think logically to be able to drive something, so I've got to break it down. So what I've recognized is the way to solve or get AI into some of these things is to work at layers. So the layer I'm working at is purely at the medical device layer. How do I get that in front of a nurse, and how will that work? One of the challenges that I see of there is I've talked to over 15 or 20 nurses over the last year all across the country, representing this product, and most of them like the value. But the challenge is they don't have the decision-making capability to drive that. That's a real weakness in the system. Because what we're doing is we're doing top-down drives. So some large company is going to show up with a big product and drive it down from the top, and not understanding whether the device, or the technology actually works and doesn't increase the workload on a nurse. It's just because it sounds really good and it's going to be really good. So that's some of the hurdles I think we've got to figure out how to get around.
My answer is pretty simple, and we all know it's AI literacy. I have the opportunity of working with new graduates that come in from the pharmacy technician programs, HIT programs, HIM programs. And someone mentioned it earlier where there was a difference between AI literacy and technology literacy, where yes, our students are coming in knowing how to use social, knowing how to use their iPhones, but then we ask them to create a spreadsheet. I ask them to put information from the EMR into Power BI, create a Tableau infographic for me so I can send it to my executive team. And there's a deer in headlights look every time I ask them to do something. And so just as simple with technology, I see it with AI. Where I'm saying, okay, we're going to scrub all ICD-10 codes for some type of diagnoses that we're having issues with. And they're like, what do you mean? I'm like, okay, well, go ahead and use AI to help scrub the information, and they're just lost. And so I'd love to start seeing our colleges continue to improve and have these discussions with their students to ensure that when they graduate and they come to us in the workforce, they're prepared to do some, I would consider, basic data analytics and information draws.
So at the macro level, I think it's about managing speed of innovation and ensuring that there's proper guardrails, and that's a lot easier said than done. There are, governing bodies that are doing their best to kind of stay ahead of this, but turns out AI is kind of hard to stay ahead of. The innovation's moving so fast. So I'd say that's a hurdle, maybe a kind of micro solution. And I don't know if I'm misusing your term of layers, but I liked that kind of approach of, bottom up. It's like, well, okay, so what can we do as a startup in our space? Well, we're going to invest in AI to make patient and clinicians' lives easier, and we're going to be testing it and verifying it every step of the way. And because, of course, like our livelihoods depend on it. It has to work, and mistakes will occur. However, we need to minimize those mistakes and have means by which we can address them quickly so AI actually is a beneficial deliverable for our product. And so I just think like the hurdle is speed and calibrating speed with managing the guardrails. And I think one way to do it from the bottom up is, make sure that your product works and is utilizing AI in an effective way.
I'd probably say in one word, trust is why I see that as a hurdle for AI within healthcare. As a clinician, trust in what's out there, because again, we always hear, well, Dr. Google is getting their stuff from any and everywhere, right? As long as it exists on the internet, you can pull that information when you ask a question. And so I think for me as a clinician, trust in the data that exists that is providing me with the recommendation. I am not saying that I'm not already probably doing that, because if I'm going into up-to-date, if I'm going into clinical pharmacology, I'm doing that in all these different spaces. I've got 50 tabs open versus I can go with AI and ask the one question and it pulls it all for me, but it may pull additional things that are not necessarily accurate. So for me, engaging as much as I possibly could has a lot to do with trust. But also on the other side, I think of the patients, that they have to have a level of trust in me as a clinician, that whatever I'm doing is based on that best evidence. We talk about evidence-based practice and research and all of these things. I don't know that today I trust what I'm receiving in certain spaces is built on accurate data, because we all know as academics in the room that the data can tell us whatever we want it to tell us, right? And so I would say it's that one word for me that's the hurdle, is trust of what's there.
Go ahead.
Hello. Trust and transparency. So you mentioned Google and the algorithms. I mean, there are such things as black box algorithms, and we have to root that out. It is a thing in tech. I mean, Facebook's super guilty of it. And if you ever hear a tech company saying that it's too complicated to explain, red flag. Not just a tech company, anybody, right? And so I think, you're absolutely right. Trust, and how do we ensure that there's transparency in how these algorithms are being used? Because that's pretty important to protect the patient.
So I spent quite a bit of time thinking about this, and I'll give you a framework to do this. I think it'll work. Take your 5 fingers, each A. First A is the most important, which is alignment. Is your organization aligned? AI, has been said multiple times today, is just a tool to achieve an end. Are you all agreed on the end in a very specific situation? And that's part of the reason why the trust isn't there, is because what I find is there is severe lack of communication across the hierarchy of the organization. The executives, the CEOs, the C-suite, they have certain expectations. The practitioners and the clinicians have a completely different set of expectations. The administrative staff have completely different burdens, and none of them are aligned. So that's the first thing and the college, I think, can do a really good job of helping align those expectations just through exercises, through like scenarios and workshops, bringing people together across various layers in an organization and running those workshops, it's just a wonderful way of achieving alignment. The second is also something that builds trust, which is authorization. What are we doing? Why are we doing it? Who agrees to do it? And what is their role? How are they authorized to do it? How do you protect everything from happening by governing and authorizing things? The third is the most important one, which I call advancement, which is the workforce. If we do not re-engineer our workforce, I want to throw a shout out to my friend Don over there, Interim Dean of Continuing Education. He and I have talked about this only for 10 years. It's because if we do not change the workforce, this was my aha moment, to become AI friendly. Everybody should have their sandboxes. They should be given the freedom to play in that sandbox, but it should be a sandbox. It should not be contaminated with anything from anybody else, because AI will continuously learn, so it can learn for them. So they have to become comfortable and get over the fear and hesitancy, because it's their own personal sandbox, it's their own game. So you have alignment, authorization, advancement, and then the application. What exactly, we talked about alerts, we talked about revenue cycle, we talked about data and analytics. What are the applications? Because now you have everybody curious and wanting to do, and only then do you talk technology. The technology I call appliance. So if you have these 5 A's, then you drive the operational management afterwards, because now at least you got the basics right. That's what I'm trying to do. I'm trying to get people to think like that, but everybody jumps into technology and operations immediately. And anybody that I've talked to about AI has cautioned over and over again, that's a disaster.
In one sentence, what is your recommendation to those in the audience interested in integrating AI into their practice, and what advice would you give them to navigate this evolving landscape?
Start small. I think that's one thing that I've told some of my managers. Going on, there we go. Is start small. Like, for us in the rev cycle, I have front office, middle office, back office. Front office, what are my issues? Data entry. Let's scan our insurance cards in. Let's start utilizing AI to place that into our EMR system. My middle office, what's going on with the prior authorizations? Oh, we're missing information. We're missing ICD-10 codes. We're getting it denied. Okay, let's automate this process. My back end office, collections, denials, payment posting. Speed it up. I need it faster. I need that money faster. Identify where the denials are happening, and let's clean it up. And so each of my different areas of like managers or directors would start small, use AI to integrate and improve operational efficiencies.
I like that. I'll say start. Literally.
Yeah.
Dive in.
Yeah.
Use it, because it can benefit your business. It can benefit the patient experience and the clinician experience.
I'd say competency-based variable time for education and orientation. You said one sentence.
Yeah, I would say do it in a governed way.
As I said earlier, I see AI purely as a tool. It has no other value. So the only value we should focus on is the outcome. Is it better, cheaper, or faster? And it's simple enough to use so that in the workflow that you're currently in, it works better.
What questions from the audience for this fantastic panel? Give a second. Estrella is running. Go on, sir.
Absolutely, yeah, no, it's a great question. Everything we do is HIPAA compliant. All patient data is anonymized.
But it will go before court at some in my profession. Like, have you? I guess I'm not So like, who's verified that, okay, this document will hold up in court. If I trust what you're talking about, that soap note verified, this will be okay. You will be protected.
So we do, from the get-go, with lawyers, for sure, to not just protect, to essentially protect all involved. And so we anonymize the data, we put it in the hands of hospital clinicians, and this is all basically a tool for them, but we don't ever see, we anonymize that data, we don't see it. There ain't no black box algorithms where we're living, it's just not how we're gonna build it, especially as a
Real quick, burnout. Not to jump, because I'm gonna come back to this. Burnout is not just how fast you guarantee the faster you soap note. Hope you get soap notes, but they're gonna add on to patients too. And it's not just patients. It's not just patients. It's your patients, leaving the x-ray, leaving the lab, responding to emergencies, and every 10 minutes, somebody from the healthcare team is knocking on your foot. All of it. The better you get at putting it, what they're gonna put on it. So,
yeah.
Oh,
sorry.
So, not just the faster you all that
That's great guidance. Yeah.
what are y'all doing about that?
I love it. Well, look, I mean, we're starting small, right? We are starting with automating soap notes, and we're listening to the feedback from, the clinicians closely. We are humble. We do not claim to have all the answers. In fact, it's oftentimes the clinicians that are, I would say 80% of the time, the clinicians are driving our roadmap, not vice versa, right? So we're starting small, and based on the clinician feedback, if it's working for them, if it's making their lives easier, great. If it's adding complication, then we're gonna strip it out.
Real quick, nobody here is from UTMB or TDC. I love my job. Nobody? All right, we good. So, okay, I like that, but so you need to have, in order for this to be beneficial, like, because we're headed by a team of physicians, they need to be in here. They can hear that, because I promise you, as they leave the floor, they see you doing more, they're just going to add on to you, and it never ends, but I'm not complaining. And then how is this any different than the current Dragon system? Because
I'd need you to explain the Dragon system. I'm not familiar.
So I'm seeing a patient. There's software now. There's a microphone on. As I'm talking, the Dragon is already making my note for me, and it's a template. So I go. So say this patient has COVID versus somebody has hepatitis. I just go in there, make a few adjustments, and I order my labs and all that. And that's another thing. The software you're doing. Say they have hepatitis. Will it already send a referral to virology for me? Like, what's the next step after the soap note's complete? Is it doing that already?
So this is good. This is bigger vision. It would be scope creep for us, though.
Okay.
So we're focused on PTs, OTs, utilizing VR as a tool to empower clinicians and patients to get better results. That's the scope we're focused on. We're not trying to solve what you're suggesting.
Oh no, and anybody, y'all can. I don't want to hog this, so y'all can jump in. So then, okay, so it's potentially will be better than the current, like the Dragon system. Okay. Thank you. And
Thank you.
I don't want to take up too much of your time. Sajol? Currently, right now, like say you're in a hospital setting and you're on a certain floor, they already have a certain team in a certain room that's currently reading real-life EKGs 24 hours a day.
Correct.
How will you augment this? We're using the word augment. How would this software, what you're doing, augment this and be more efficient so that if you do see something, say a patient has, normal sinus rhythm, but all of a sudden they jump to AFib, like how much different than what they have right now in place, what you plan on doing?
Right, so the actual application is not for an ICU-based environment in a hospital because we can't compete there. Where we see the value is if you've had a stroke or any cardiac event and you're sent to a step-down place, that's where monitoring is not there. In fact, I've gone to Baylor Scott and the rehab places, there's only 2 beds out of 85 that are ICU'd in, right? So the other 85 beds is really what we want to cover, and so that we can get these early things. So what we'll be doing is every morning you'll get a report showing you all the events that occurred. How many falls occurred. If they were not there, then we caught that fall. you know, how many irregular heart rates were there, how many apnea events, the AHI, all that shows up in a report every morning with a history going back 30 days. In fact, one of the patients we're working with right now at PAM Health, we could show that after whatever they had, which was, you know, since it's all anonymous to us, we don't know the data, their heart rates were running, this person's heart rate was running at 120, 130 every night, right, for over a week. And so we called the nurse and they said, oh yeah, that doesn't look good. So they made some adjustment in the medication. The next day we saw it all within a 70 BPM range, right? So this history is what you really want to try to get out. It's, now we can give you alerts on tachycardia and bradycardia because we know when that occurs. Within 15 seconds you'll get an alert. Whether you want to use it or not, that's a choice you can make. Right.
Can we have a hand of applause for that incredible gentleman? If every nurse was that engaged as AI is developed, the world would be a better place. And by the way, he's an ACC nurse. Woo! Back to you, Dr. Vaughn.
Toni, this is actually for you. You were talking about the Jane system that you were using to assess clinicians and whether they could be moved around to different areas and things. From a college perspective, and particularly from our perspective in continuing ed, we're really interested in bridging these micro skill gaps that emerge because of technological innovation, integration. And I'm wondering, does the system that you use there at St. David's, does it help to develop training plans to bridge those micro skill gaps that you identified with the Jane assessment system?
Absolutely, that's exactly how it works when I speak to the individualized process. And initially when we started, it would give you, oh, do all of this education. So now it is going to say to that individual clinician, these are the areas that you need to focus on, whether it's related to clinical judgment, so that means their experiences on the unit and what that preceptor needs to support them through, or what additional maybe things that we are stepping into the VR space, or we can do in high fidelity simulation to support their learning in that space. The most recent thing that we are rolling out as we speak is adding a lot of demographic data to it. So not just to bridge those gaps within our environment when they show up, but that we can give feedback to ACC and say, these are the things that we've noticed in the traditional student group that as they come into our organization, or these are the things that we might find helpful for your non-traditional students, or the surgical techs that are coming from all of the different spaces across Austin. This is a common theme of a space that we need to close. So that's now, and that's mostly demographic. We are, that was birthed out of our need for support of our internationally educated nurses, understanding what their experiences are when they transition to us, because they need a little bit of help just to take the test, right, as a transition. So long answer to yes, we do personalize, and second, we will be able to collaborate with our academic partners to strengthen their programs so that the students that come to us have the best experience possible as they transition into professional practice.